Because if you can't sleep, you're stressed out all day because you're tired and you're sleepy. Then run into the bathroom every 5 minutes. What is that? Even at night, and then you're crazy, you're cranky, and you can't remember things. You walk away and you're talking to people mid sentence. You don't know what you're talking about. It's like you're literally going crazy with your hormones.
Welcome to the Vision Creator Podcast, from corporate to creator, with your hosts, Pamela Martino and Debbie Williams.
Thank you, Dr. Amar, for joining us today. We want to welcome Dr. Amar to the Vision Creator Podcast. This is a hot topic for many of us going through the stage of life or the change of life of menopause. Dr. Amar is my personal doctor and my sister's personal doctor, Patrice Pullen, and he has helped both of us so much to make this transition from perimenopause into menopause and now postmenopause. So I know this is a hot topic for many of us. So we're going to go ahead and kick it off. Just a few housekeeping items. If you have a question, please put them in the chat. Patrice will read your questions off. If you would like to use your voice, please feel free to ask to come off of mute, and we will get your questions answered, or you'll be allowed to speak using your own voice to ask questions. So let's just kick off. Dr. Amar, women are often asked, what is their superpower?
Yes.
New answer needs to be estrogen. That needs to be the new answer to that question.
Okay.
Without the proper levels, you feel like scrambled eggs, right? So we now know that, perimenopause, you're just trying to figure out what's going on with your body. But we now know that it's estrogen, low estrogen. And so now that is the superpower for most women. So
yes.
let's kick off. Debbie, what do you think about that? Superpower, estrogen?
Absolutely. It could be high estrogen, it could be low estrogen, it could be high cortisol, it could be low, it could be anything, right? 1 minute you're hot, 1 minute you're cold, 1 minute you're going crazy, you're going cuckoo for Cocoa Puff, and the next minute you're very intellectual. 1 minute you're nice to your husband or your spouse or your significant other, and the next minute you got a dagger trying to kill them, right? 1 minute you walk into the kitchen and you turn the stove on and you cook, and the next minute you walk away, come back hours later, and the stove is still on, and thank God you didn't burn the house down. So menopause or perimenopause or whatever you want to call it, because there's different definitions. It's interesting. So we're gonna demystify all the things that it is and all the things is not, and also we're gonna get help, because a lot of people are suffering in silence with this thing, and it's not necessary, right? There's a lot of resources, and thank God for Dr. Amar, who's going to help us get the help that we need to solve this. So
Yes, absolutely. And so while there are officially only 34 recognized symptoms commonly cited by medical organizations, hormone fluctuations can trigger over 60 different physical, mental, and sensory changes in the body. Every person's journey is unique, and some experiences no symptoms at all. The classic and most widely recognized list consists of hot flashes, anxiety and panic attacks, brain fog and difficulty concentrating, insomnia, troubles falling asleep, urinary incontinence or leaking, joint pain, muscle aches and tension, hair loss, or changes in hair texture.
Yep.
So a part of this podcast, we're going to address the 3 stages of menopause, which is perimenopause, menopause, and postmenopause. So Dr. Amar,
yes,
let's start with, what is the one thing about menopause that surprises every woman who walks in your office?
The one thing that surprises all women about menopause, I guess it's that it can be very different depending on the woman and their family history, what their symptoms might be. Some women, they don't ever have hot flashes. Other women go through menopause and there's no vaginal dryness, no pain. Those are fine, but they have other issues, maybe the sleep. And some of those symptoms, when you go through them, you can sometimes anticipate what those labs are going to be based off those symptoms. So, testosterone being low has its own suite of symptoms. Progesterone being low has its own suite of symptoms. Estrogen is considered kind of the bad guy. As right when it drops, oh, that's menopause. But a lot of the symptoms may not even be an estrogen issue. It's progesterone. So menopause is bigger than just estrogen, in my opinion.
Hmm. That's good because like I said early on, that should be our superpower is that women need estrogen. So you think it's more progesterone than estrogen that is
So
No,
let's,
missing.
I think it's all of them together.
yeah, because there's a ratio you have to look at with the estrogen and progesterone too, right? They're like
Yes.
team players, all the key hormones, estrogen, progesterone, and there's some the other ones, DHA,
Yes.
all the things, right? So
Yes.
so do you see, even though broadly they're different, do you see there's homogeneity across ethnicities? Like African American, you may see a type of symptom versus non,
Yes.
Caucasian and things like that. Do you see that?
Yes, so it can be from ancestry. I haven't like done any studies on this. This is just, what I see in my clinical practice. But
Hmm.
yes, amongst patients of African ancestry, we tend to see more fibroids, more
Mm,
estrogen dominant symptoms, and then the classic sleep issues, which are usually tied to progesterone.
mm.
Typically, we see the progesterone will drop first, but even in, family or even in genetic makeup group, there can be variants, but yeah, there's general trends.
Yeah. And I will have to say the sleep deprivation is real. Falling asleep, staying asleep, getting up in the middle of the night, using the bathroom. Your sleep is so broken. And so my mom often asks, I mean, because I'm up to like 1:30 in the morning. And I purposely do that in a way so I can sleep through the night and I won't be up, throughout the night using the restroom and, things like that. And so it just helps me, just have a more sound sleep. And then also thanks to Dr. Amar, he has given me some supplements that help as well. And we'll get to that, but there are things out there now that help us women make this transition, and it's not as hard as maybe it was, in our parents' generation. So I'm very thankful to you for that, Dr. Amar, and that's why I wanted you to come on to our podcast and talk to, all the females that may be going through some variation, that are probably going through some variation of this phase. So let's talk about let's go back. Let's backtrack a little bit. So the three stages we talked about: perimenopause, menopause, and then postmenopause. Give us an explanation. Explain what that is and what each one of those mean. Start with
Yeah,
perimenopause.
yeah. So typically perimenopause, there's a lot of discussion. There's not like a one unified diagnosis, idea, but generally it's going to mean that the cycle is still coming. It might be interrupted. It might be changing. It might be changing in character. And then there'll be other associated hormonal symptoms, libido drops, or maybe body composition is changing, but the patient is still having a cycle. So, like the technical definition, that would be perimenopause. Some hormones are shifting, and the patient's kind of detecting that. And then it can happen, late 30s into 40s into the early 50s. And then the average woman will go into menopause around age 50 plus or minus 5 years on either end, depending on family.
Wow.
And I will say, and I didn't know this at the time, that perimenopause started for me probably about 36, 37. I thought literally there was something wrong with me, right? Because I was at work and I'm like, why can't I see these people? I'd be on a Zoom call and like I couldn't even see straight. Like I couldn't really focus in. And I didn't think menopause because I'm in my 30s. You don't
Yeah.
make that association. But after my cycle ended as early as it did in my 40s, like 47, 48, when I look back, I'm like, that's because the 10-year window that, most people, I'm like, that's exactly what was going on. I just did not know. And
Yeah.
so it was,
It lasts for 10 years approximately on average, Dr. Moore.
Yeah, so some will say like, 5 to 10 years. Before, like during my training years, it was more of like, oh, just the first 2 years before the cycle goes. But now there's a lot of understanding that no, we see some hormone shifts that happen earlier, and then there's like a more sudden drop as you get to those last couple years. But yeah, there's changes that happen, 10 years ahead, 5 years ahead from the time that
That
the
makes
the full
sense.
cycle goes gone.
Yeah, that makes sense. Because for me, it was the stubborn weight loss. It's like you go from a place where you can lose weight with no problem to everything you do just doesn't work, and it gets worse. You get this big stomach, and it's just like your body just like, who's this person, right?
For me, with that, I always have to say that you also have to tie in the cortisol
Yes,
component,
that's right.
even though that's not a uniquely female phenomenon. That cortisol issue, for a lot of my patients, is a driver, in my opinion,
Yes.
for having those early perimenopausal symptoms because they kind of choose through your other hormones.
Okay, let's go now over menopause and let's kind of define what, menopause is, because that's a short period of time, right? That's only 12 months. I'll let you go into detail, but when the frequent word is menopause, but when you think of menopause, you think it's all the things that we talked about, the hot flashes, blah, blah. It encompasses that, but it's that 12 month. You're not considered menopause until you're not having a cycle for 12 months.
Yeah, so I mean that's the classic clinical definition. No cycle or no menses for 12 months straight. So some patients can be almost perimenopause and it's like 8 months, 6 months, and then the cycle comes back and
Yeah.
it can be really frustrating because some patients are like, okay, I'm done with this. I get it. But yeah, it can take that's the classic definition. So for me, like when I see a patient, and there's a lot of like idea of like categorizing, like, are you perimenopause? Are you postmenopause? To me, those are human constructs of how we try to understand the situation. But really, it's just based off the labs and what the patient needs at that time. So, like, we have to say, hey, like, are you closer to menopause than perimenopause? Well, we could see and we can see how your body responds and kind of ask, oh, how did your older sister deal with it? Or how did your mom deal with it? But yeah, technically it's the 12 month window.
And I think the other important thing people need to understand is, um, so again, menopause is just that small segment. When you hear menopause, it's like it's all encompassing, but it really isn't. It's just that 12-month period. And then you spend the majority of or the rest of your life, whether you're 50 or 55 in postmenopause, right? So
Yes.
talk a little bit about postmenopause and things that people need to know going into postmenopause and how we prepare, right? When we're in that phase, should we be taking vitamins, you know, working with our doctors to get our hormone levels checked? So we can not, maybe the effects won't be so harsh, and we gingerly make that transition into postmenopause.
Yeah, so like postmenopause would be, the cycle's gone and the hormones aren't there. And so it leads to certain problems if you decide not to do hormones. And hormones are a choice. It's not like everyone needs to be on hormones. Some women, they don't want to be on hormones and they do great through menopause. It's not too bad. And if they decide, hey, this is not worth, I don't want to like mess around with things, then that's fine. But the symptoms, that we will see with menopause, postmenopause patients, bone loss,
Mm.
so osteoporosis, osteopenia, where the bones start to thin, because if you don't have enough hormones, then you can't keep the bones strong. And that's why the classic story is, a patient is postmenopausal and then has a fall, and then we look into fracture risk. So if we do hormones, it can help prevent that loss. But if you wait too long, that loss can have already started. So
Mm.
there's some theoretical things that you could do there. And then the other one would be pelvic floor dysfunction. So the pelvic floor is the lower part where the genitals are and all the other structures there, and they need to be strong. But if you don't have your hormones, over time you can have weakness in that pelvic floor, which can lead to problems, prolapse, all sorts of other issues. So like what you need with the hormones also should be tailored to what your goals are. So like I can do a low dose vaginal hormone just to help with pelvic floor, but we don't have to treat that patient with the same level of hormones or the same goals if our goal is bone growth, because bone
Mm.
growth is going to have a much higher standard of hormone dosings. So that opens up like a lot of options. So um, it's not as simple as, oh, you want hormones, here's the hormone protocol. It's more of like, hey, what do you need? And what are your goals? What are you comfortable with? Because yes, people talk about, oh, well, breast cancer, ovarian cancer. The hormones, it's a lot of mixed opinions on that. Obviously, they got rid of the black label recently.
Right.
It was based off the Women's Health Initiative, which I think was flawed for some reasons, and we can get into that later. But hormones can be a choice, but it doesn't have to be like one size fits all. Yeah.
And just to piggyback on that, doctor, so like you talked about the study that was synthetic versus what we're dealing with now, which is bioidentical,
Bioidentical.
which is could be mushrooms or yams, wild yams, which is why one of the reasons that you can't get it like you they have to be compounded because it's natural. It's essentially natural. Is that am I saying that correctly or am I?
Yeah. So like say if you're a drug company and
Uh-huh.
if you're a drug company and you're making drugs, you want to make a patent for something.
Oh, that's right.
But the laws are you can't patent something that's naturally occurring.
Mm.
So what you have to do is you have to take the estrogen hormone and then modify it. So if you have any one who's been on birth control pills, it usually doesn't say estrogen and progesterone. It might say like norethindrone or ethinyl estradiol. So they add in chemical structure and then they
Yeah.
mix it up with other things. And then they can say, hey, this is a novel drug. Now I can
Mhm.
take it to market. I have a patent for it. So there's a reason that it's done that way. So when we do bioidentical, what is the benefit? Not everyone can handle. You go to a bar, you get five people, they all take a tequila shot. People are going to respond differently to that shot, or even any other drug, even a medication. Some people get side effects with a medicine for sleep, but then their friend loves it.
Mhm.
uh, that metabolism can change depending on how they structurally changed the hormone molecule. And so in some women, when you do the false estrogens, there's a thought that it can feed bad things, cancer, or
Mm.
create problems or dysfunction.
And
Gotcha, gotcha. So the
yeah,
synthetic ones versus because even with the birth control pill, some people I couldn't take it. It was just too much, and I think it was
Yeah.
because it was synthetic and just created. But with these natural hormones, it's like it just blends right in with the body just
Mhm.
absorb
Because
it.
yeah, so
It's
bioidentical
natural.
meaning, yeah, bioidentical means it's literally the same thing your body makes, not chemically changed. So it's kind of like, I kind of imagine like, have you ever seen those machines where like the ball comes down and there's like
Yes.
little pins?
Mm-hmm.
If your metabolism can change, it can move something to a wrong place if it's slightly different, the molecule.
Yes.
And so that's why it was that was one of the flaws that they use non-bioidentical hormones. The second flaw was they were giving hormones, but then not checking their work.
Mm.
So, people would just say, okay, you want hormones, here's birth control, just stay on it for 20
Okay.
years.
Which
But
is
how do you
terrible.
know what the dose is? Is it
Mm.
accurate? Is it good for the patient? How much are you getting? Is it actually circulating? And then there's also theories of liver metabolism and what we call first pass metabolism. So when you take a pill, it hits the body
Yeah.
different than if we do a topical or a patch. And
Mm-hmm.
we find that when typically when I'm doing estrogen, I almost never do estrogen orally, like maybe once in a while, but
Mm-hmm.
it's generally considered like bad practice to do that because it can potentially fuel fibroid growth.
I was going
Uh,
to say that the 5 words. Yeah, I was
that's a
definitely.
classic one.
Yeah, because with those birth control pills, some of it contribute. Now, I could be wrong. Contribute to fibroids, right? You talked about fibroids in the Afro community.
Yes,
Okay,
definitely.
it is true. Okay, I thought so. Okay, all right.
Yeah. So that is a huge thing I've seen in just from my practice and what I've seen with my patients of African ancestry. We've seen that a lot.
Okay, good. Okay, sorry, Pamela. Go ahead.
No,
I interrupted you.
on the same thread, right? So we you keep talking about estrogen. What is it about estrogen that is the great regulator in our body? Why is that the great regulator?
So estrogen is helpful for skin. It's helpful for obviously libido. It's part of the female structure. Having the estrogen there allows the vaginal wall to be lubricated and then for all the structures to be strong. So it can help with the pelvic floor. Estrogen is also important for bone health, as we discussed. And then that's why when some women go into menopause, it's just joint pain. And
Mm.
you'll go on a
That's
hunt looking for autoimmune stuff and you won't find it. And then you're like, okay, well, I guess it's the hormones. So yeah,
Mm.
hormones, the estrogen can do a lot of things. It's the essential thing that makes women women, in my
Mm.
opinion, that estrogen. But it's not as simple as just estrogen. It also has to be the combination and the balance of estrogen, progesterone, testosterone, pregnenolone, DHEA,
That's
cortisol. They
awesome.
all have like an interplay.
Yeah.
Let's
So
talk
just,
about that joint pain
yeah, I was going to
because
say that joint pain, the
yes, I mean,
collagen, right? You lose your collagen with the estrogen, right,
Yes,
doctor?
with the collagen, yes.
So you
well,
don't have to
the
take, some people take over the counter collagen, but if your estrogen levels okay, you get your skin, your all the things that collagen feeds, right? Is that a
Yeah.
fair
So that's
assumption?
why even now there are people doing microdose estrogen face cream
mm,
for
Oh,
anti-aging.
mm,
So you can do that, but anything you put on your body, especially the steroid hormones, it is going to be absorbed systemically. So
mm.
if you're doing that, you should be mindful because for some women, if you're doing too much topical estrogen, even if you're not intending it to be systemic, it will have a systemic effect. So you have to kind of check your work, make sure everything looks good.
I want to go back to the joint pain because
Yeah.
my hip. And I went to the doctor, my this is my primary care. And so he started asking me, "Are you having any hip pain?" And I told him, a little bit because he was like, "Well, you're still too young for a hip replacement." So it was like he went immediately to like surgery, hip replacement. And so many women don't make the correlation between your joints and your hip and things hurting and associate that with menopause. It
yes.
very much so is. And Debbie and I had this conversation earlier this week where she had a friend, I guess, who also did not make that correlation. And
She,
this woman ended up having a
she's
double hip
double
replacement,
hip. Yeah.
Oh,
double
that's
hip
horrible.
replacement. And then she was
Yeah.
50 something.
In the
Not
50s.
even
Yeah.
her
That's
doctor
way
didn't
too
even
early.
explain to her it could be,
Collagen, like a collagen.
or
Yeah.
menopause related to menopause. She told her it was aging, I think is what you said, Debbie. That was,
Yeah, yeah, and you talked about the shoulder pain. So if it's just that right hip, a lot of people say that right hip start hurting. They think because they're sedentary, they're at the computers a lot, which some of that could be. But once you get your levels dosed and modified, it's a whole different world.
yeah.
You're not suffering. I mean, because sometimes the pain, even just trying to get out, I thought it was my mattress at one point, and I changed. I must have brought like two mattresses, and I'm thinking two brand new mattresses throughout one and got another one, and I'm realizing like no, it's not my mattress. It's my joints. It's all the things. And then again, once I got treated for that, now I can sleep on any mattress, and I don't have all that stiffness and pain and all the things that comes with having your hormones imbalanced. So do you hear that, Dr. Mart? Did they say that right hip and that do they specify? Is there a common area that people complain about when it comes to joints?
Right hip is common, but it can be anywhere. But I have some patients who say they just get kind of aching in the bones,
Oh
so to
yeah,
speak.
sorry. Yeah,
And then
it
in other
hurts.
patients, it actually can, when we're in menopause, the bone thinning, we can see compression fractures in the
Ooh.
vertebrae,
Oh,
which has happened to my grandmother. So
oh,
should that is a common thing, and we know that menopause plays a role with the bones being weak. But yes,
mm,
um, if someone comes in with hip pain, obviously surgery should always be your last thing. And so I'd be curious to see what those x-rays were of that patient who got that hip replacement at that age, because if you're getting hip replacement at age 50, from my experience, the only way you could do that is if you were like some sort of marathon runner or if you really abused your hip. If you were sedentary, that's not
mm,
going to cause your joint to degrade. So you have
mm.
to question that. And the x-ray will usually say, hey, you've got severe arthritis, you're bone on bone. But arthritis could be even bigger than that. Autoimmune,
Okay.
inflammatory, injury, infection. So like
Mm.
usually menopause can cause bone pain, but it's usually like lower on my list of usual suspects.
But because of lack of collagen, can it hide itself as arthritis? Because
Yes.
okay, because yeah, because that was one of the things. Oh, maybe it's arthritis. I'm like, the devil is a lie. We have no art. This is because when you start getting stiff like that, and it starts feeling like you have arthritis, but it's really a lack of collagen because of all the imbalances with your hormones. So,
But
okay,
Dr.
Yeah.
Pamela.
Yeah, Dr. Mar, I was just going to say, so I was experiencing right hip pain. And then after you put me on the cream, the the estrogen cream, I felt so much, I didn't feel bad physically, but I felt better. And although I was having a little bit of side effects with the cream, I don't want to stop unless it's something critical that I need to stop for with the cream. But I felt immediately better. Like my hip, although I get a little bit of joint pain, but it's not like debilitating, you know. And so, I definitely want to advocate for that. I don't know if my primary care physician would have offered that to me. He was wanted to give me some estradiol and something else. And he was like, if you don't take one, you're going to have a cycle. Your cycle's going to come back on. I'm like, we can't do that.
No,
That's not
can't
an
do that.
option for me.
We can't
And
do that one.
you can't do that. And
No more
so,
cycles.
no, we're done with that. And so I'm very thankful for the supplements. I mean, I take the pregnenolone, I take the adrenal gland. I want to talk about how that adrenal support, what that does for our bodies. I do the
Sure.
cream, I take the DHEA. And now you have to make the adjustments based on how your body feels. And so initially, you told me to take the DHEA and the cream every day. And my body, I don't know if it was just a shock of something new,
It could
but
be
I
too
had
much.
to, yes, I had to taper it down where the
Yeah.
DHEA I do Monday, Wednesday, and Friday, and the cream I do Tuesday and Thursday. And the
Yeah.
cream I've actually had to adjust again because I don't know. I mean, I know I'm on the lowest dose, but it gives me some kind of weird sensation like in my stomach and my limbs feel weird. But anyway, so, but I know that it has helped me. It has helped me tremendously. And so everything that I'm taking is from a natural perspective, a supplement versus something synthetic. So I just want to put
Yeah.
that out there. I'm very grateful for those things that you've offered.
Yeah, of course. You're
So
very
let's
welcome.
Thank you. So okay, there's two things that I want to talk, and then we're going to open up because we have a lot of people that have joined. And, I know all of my friends, family, and other people who've invited other people. There's questions out here because we're kind of all going through the same thing.
Everybody's suffering.
Everybody
Well,
is suffering.
we're suffering saints out here. Well, not me. I'm good, but I was a suffering saint.
So, how do husbands support their wives? This is, I've heard some women say, that their husbands say that they're just enraged and they, can't even make a simple statement. And they're like, their wives are blowing their heads off. Like, what are you talking about?
Yeah.
How can husbands or significant others help their wives or, their partner through this
Yeah.
transition?
And then also intimacy. Don't forget that
Uh,
because for some women, it's very painful to have intimacy with their husband because the walls are because of the aging thing. But with supplements, that can go away. But you can talk about that. It's the whole complete picture because it's not just them being angry, but it's them don't touch me, don't touch me.
Yeah. So that definitely overstimulated, that plays a role, especially if you have a high cortisol case where there's a lot of basically I kind of think of it as you get closer to the perimenopause, your ability to kind of balance everything and have that resiliency will diminish as time passes because the hormone buffer that you have is lost. So as a guy, what do we need to do? Have patience,
hmm.
understand that this is a change, and it's hard. And I always think of those funny videos where they show, the guys with the, PMS pain and they start crying. It's something that we as guys, we've got it easy, because ladies' hormones is a lot more complex. There's a lot more finesse.
Mm.
With my male patients, we'll put, I'll see husband, wife, back-to-back visits. They'll be in the office together and I'll do one
Oh,
and we'll
that's
do the
good.
other. And then I will put a program for both. We'll get the hormones going. I'll start everything. The guy will always respond quicker and he has an easier time of it. So as
Yeah,
guys, we have it very easy. I'll be the
yeah.
first to admit it. So we have to just understand like, hey, it's easy being a guy. We don't have to worry about these things.
And you also too have some women who have low testosterone too, because I've heard where
Yes.
some women they had a low libido and they was like, "Hey, what's wrong with me?" You know, I'm not interested in having sex with my husband. And so for some, they need test. Have you ever given women testosterone because their
Yes.
hormone? Okay.
Yes. So there's like one of the strategies for hormones is to just do mega doses of testosterone.
Mm-hmm.
And you could do that through the pellet. You may have come across it. It's called
Mm-hmm.
BioT.
Mm-hmm.
That
I
makes
see.
it work pretty well. For some patients, they like it. I've gone in the medicine that I do, I deal with a lot of chronically ill patients. So like hormones is one of the things I do, but it's not the only thing I do. And so for those patients, like if they can't detox, right, with
Mhm.
that little ball on the pins falling down, if they
Mhm.
have problems with detox, then when you give mega dose hormones like that, it can sometimes trigger problems. Like some patients have said, "Oh, my friend went for the bio T and she's amazing and she's chasing her husband around and she feels great." And then another woman will get the peptide, the pellet, and it creates horrible acne. And then they can't hit the high notes when they go to church anymore
Oh
when they
wow.
sing. So it
Oh
can
wow.
be a lot. So with testosterone, you have to really know what you're doing and be meet the patient where they're at, and then even look at their history. Like, okay, did you have PCOS when
Mm.
you're in your when you're in your premenopausal era, like when you're in your 20s or 30s, because that can tell you maybe how that patient, as a hint, how will they respond to testosterone.
Mm. Mm.
So I usually don't do testosterone all at once. I like to start the estrogen, progesterone, kind of get that going, get that locked in, and then we say, okay, we got those things good. Okay, vaginal pain, we got that handled. Lubrication's good. We're not having pain. I'm doing okay. My mood's getting better. My sleep's better. Libido still needs some work. We look at the testosterone. Okay, it needs some help. Then I like to kind of add that in as a second pass, but that's just my habit.
So just to piggyback on that, because again, to go back to the fibroids, right? Fibroids is a high level of estrogen, and meaning that you could have some xenoestrogens, which is fake estrogens, which comes from plastic, right?
Yeah,
So plastic comes from many forms, right? I know we like to wear our hair, like African American women, we like different wigs and nice, clothing. A lot of cheaper clothing, such as the Timu and all the things. But
the
those things are
polyesters.
yeah, but polyester is plastic. Those things. So you're, and it goes through your skin. It absorbs through your skin. Would you say a lot of the high estrogen that, because if you're too high, you can't even take hormone therapy because you're too high, right? So would you say some of the plastic on the clothes we wear and the things we put on ourselves, is it contributing to some of the fibroids and some of the issues that we're having with
Oh,
our?
most definitely. Most
That's true.
definitely. And I would
Yeah.
also say, like, if you look at some of the chemicals that we come up, all the stuff that 3M is doing for nonstick, all that stuff,
Mm.
a lot of those are known xenoestrogens. And we see, there's cases of people like, oh, with babies, right? Warming up the milk in a
Milk.
plastic bottle, and then
Oh
we
wow.
start seeing breast buds in the little one.
Oh my God.
So it's not always every patient because it goes back to that ball falling down the pins. In some patients, yes, the plastics will play a role. And so for me, that's what causes the disparity now. Like if we're talking about younger women getting into their cycle, it almost seems like every young woman has PCOS or has a hormone
Wow.
problem and needs, oh, the cramping is so bad and they needed to be on birth control for cramps. I think that's a societal environmental problem.
So I know some people think of menopause as, hot sweats, sweats at night, and or you're cold, you're hot, you're all the things. But it's so much bigger than that when you talk about whole, because I know for me, I didn't have the whole hot sweat thing. The weight thing was just really, I didn't like the big stomach and all the things and I just wanted to get to the heart of that. And as a result of searching for that, I discovered it. I was hormonally imbalanced. And I could never lose weight as long as my hormones are out of. I mean, I went to all kinds of programs. Like, what in the world? Like, where did this big stomach come from? Oh, and then I learned about skinny people with big stomachs, and they're having the same thing. It's their hormone imbalance, but it's so much bigger than just hot flashes and cold. Because even for me, once I started getting the treatment, my vision improved. Right? Like I was sharing with you guys, my optometrist was like, "What's going on with your eyesight?" I'm like, "I've just taken hormones, and it's just." So and my vision was getting terrible. So that thing totally flipped. And as I increase my dose, it gets better and better. And I can see at night. I could drive at night. Before I can, my night vision was shot. So for me, it was just so many more things in terms of, being able to manage my weight, and then also my eyesight. The hot, flashes went away, which I didn't have a lot anyway. But I sleep better. The sleep, like, oh, I was always tired. But to your point, doctor, the adrenal, because if you can't sleep, you're stressed out all day because you're tired, you're sleepy. then run into the bathroom every 5 minutes. Like what is that? Even at night, like what is this? Like 3 o'clock? Like you're just, and then you're crazy, you're cranky, and you can't remember things. You walk away and you're talking to people mid sentence. You don't know what you're talking about. It's like you're literally going crazy with your hormones. I mean,
Well,
that's what
let's
Yeah.
I
put
felt.
that question on pause, the adrenal, because I want to come back to that because in the cortisol, yeah, there's a whole conversation around that. But Adrian,
Yeah, you
Adrian
have a
Chambers,
question.
I took her off mute.
Yes,
So Adrian, if you want to speak,
yes. Can you hear me?
yes, I
Yes,
Yes,
can
I
hear
can
you.
hear you.
Awesome. Good evening, everyone.
yes.
I want to say thank you so much to my dear sister friend for having this conversation. It's a little late for me, but um, I am post-menopause, post-mental pause, post-menopause. Menopause has wreaked havoc on my life. I think the only thing that didn't happen is that I didn't lose hair.
Mm.
Yeah,
When Oprah had her special, which was so needed, it saved my life. When the neurologist came on and said of the effects that occur in the brain, I said, I'm not crazy. This is really happening. And I remembered when my body switched from menopause, perimenopause to postmenopause. I didn't even understand the whole thing. It was like the bottom dropped. It's almost like if you're on an elevator and you stop real hard, and nobody understands this. And I'm like, you guys, I'm writing a book because they said there's about 30 something symptoms. I've had 50. So my question is, what I have a sedentary job. I mean, I'm just headset to the computer. What can I do about this appetite? Because I feel like I am eating like a man who plays football. I need 3 meals, snacks. It's horrible. And the weight just, keeps coming. And then, trying to get up and walk. It's really rough. Everything else, I did get on HRT, and literally everything has reversed.
good.
I'm not. I've always been a very pleasant person, and I really turned into a non-pleasant person. I wouldn't get my gun license because I was like, I'm going to be Medea in the street.
Okay.
And I had to be honest, right? And I
Yeah.
would talk to people and they would be like, I don't know what you're talking about. I said, okay, I'm in the wrong group.
Yeah.
So that's my question. Thank you again, Pam, for hosting this
Yes,
very, very important conversation.
thank you,
Okay.
Adrian.
Thank
So
you.
let me get that question again.
The
Uh,
weight gain.
Just
What she?
the weight gain. Yes. So
Yeah.
the weight
Yeah. She's
gain.
always hungry. Yep.
Yeah. So the weight gain and actually some of that, it may actually not be only the estrogen and progesterone dropping. Oftentimes the big one for that would be cortisol. When the cortisol is high, or if the patient's in like a high stress mode, they're going to run on adrenaline. That adrenaline is going to increase hunger. If anyone has ever taken steroids for another medical condition, then they'll notice that, oh, I'm more ravenous, so I'll eat more. There's other hormones as well in play. There's leptin and ghrelin, which are hormones that play a role with metabolism and hunger. And those can also be off, and those are easy, not easy to fix, but we can modulate them with herbs or the more famous medicines that have come out now, like microdosing GLP-1s. There's a lot of options. It's not just estrogen and progesterone. You have to look at cortisols, leptin, and obviously make sure all the other hormones are fine, thyroid, etc. But yes,
Mhm.
I don't use hormone replacement just for weight. It's a component of weight, but I wouldn't say it's the only thing that can affect weight.
So when I go to my physician in
Mm,
later June this month,
yeah,
my gynecologist, because get this, I did get my menstrual cycle again after starting HRT
that can happen.
because I have fibroids. I said, "What? I never knew that." Um, but I'm okay with it because I'm like, that's okay because it's keeping this brain together. The brain fog is clearing up. I'll take that. So as far as the weight, when I go to my gynecologist, should I ask her to test for cortisol?
Yeah, so
Okay.
let me show you. I have like a nice little graph I can kind of pull up if I share my screen here. Because this is kind of what I show all my patients, which is we call it the steroid hormone pathway.
And
Okay.
doctor, could you clarify that most gyno people are not trained on menopause? Could you clarify?
Yeah, because it when you go to see your traditional GYN, it's just gonna be are you perimenopause or menopause? And then what do we do? But like even when I was in training years, it was not recommended to do bioidentical hormones or to do any hormone replacement because it was post Women's Health Initiative. So most doctors didn't do it. You would have to see someone who is interested in it, either, someone who's gone for extra conferences. There's a couple groups like A4M is one, and then the IFM is the other. Those are like the two biggest groups for hormone replacement. Now, the thing is when you look at your hormones, all your hormones, the sex hormones at least, not thyroid. Thyroid's a separate issue. All your sex hormones, what are the sex hormones? And the steroid hormones, those are all based off cholesterol. And then from cholesterol, it gets turned into pregnenolone, and then it gets turned there's a split in the river, so to speak. So you get progesterone, DHEA, testosterone, and then estrogen. Where's estrogen? Oh yeah, he's all the way on the bottom. And there's multiple estrogens. So estrogen is not as simple as one estrogen. There's estradiol, which is considered the strongest estrogen, and then there's estriol, which is a commonly used estrogen that we use in conjunction with estradiol. But to answer your question, what you can ask your doctor to order would be your pregnenolone, progesterone, cortisol, but you want to do the cortisol in the morning because the cortisol goes up and down throughout the day. And that's kind of like your wake up hormone. So, like when your cortisol is low, some patients can't get up in the morning, but then the cortisol can become aberrant. So, like, you can have high cortisol happening at 10, and that can be a reason for insomnia. But also, if you have high cortisol, that could cause weight gain. And then you'd want to look at your testosterone estrogen ratios and then DHEA, which is a precursor hormone. And then the other hormone, which is not on the steroid hormone pathway that I do all the time, is called leptin, and that's considered a weight gain hormone. So there's a lot of patients where thyroid's perfect, vitamins are perfect, hormones are locked in, weight doesn't budge. We'll check, we'll see either leptin by itself or leptin can be driven by systemic inflammation, and then you might have to address those things.
Okay, the questions are pouring in. And I think this is a great time to make the point that Dr. Amar, you are offering, is it $25
Oh yeah.
off?
Yeah, so it was just a little something my office manager came up with. I think it's $25 for new patient consult, or you could do for our IV suite, and I think we might honor both. So like if you want to do a little bit of both, that's fine. And then that's not just for me, but I also have allied practitioners at our office. My sister, she's a board certified endocrinologist. She went through all the traditional ivory tower training, and now she's recently joined us. So her name is Dr. Poonam Kalidas. And so she is taking patients. And then there's also Dr. Shah, who is our colleague. He does a lot of injections, peptides, things like that. He's taking patients as well. And then in the office, it's usually me and my sister who are taking women's hormones. Dr. Shah, he will take women's hormones, but his interest is more injections and men's health. And then we also do work with like other things that are not related to hormones, like chronic fatigue, fibromyalgia, vitamin deficiencies, post-COVID, weird things like chronic Lyme, mold toxicity. Um,
And you do
if
telehealth as well, right, doctor?
Oh yeah,
Telehealth.
we do telehealth and then we'll do Zoom visits.
Zoom. Yep.
It's good to see a patient once a year. So like if we can see you once, that's fine. But because our practice is kind of different, then we can do Zoom, phone. I have a lot of patients in other states, yeah.
Me, I'm in Charlotte and you're in Orlando. So yeah, it works 100% very well for me.
Yeah.
Thank
Yeah.
you.
So let's get to some questions here. We have a question that's asking about premenopausal. For premenopausal, is there really such a thing as frozen shoulder? And if so, please explain frozen shoulder and premenopausal. Can you explain the correlation between those two?
Yeah. So if there's a diminishment in testosterone or estrogen, it could be both or one or the other, then we can see joint pain, inflammation, and that frozen shoulder can play a role. Just as some would say, oh, my hip was giving you a problem. Similarly, we can have that frozen shoulder. But frozen shoulder is not just only due to hormones. It can be due to other things too. But we do tend to see it, interestingly enough, in that age category, 40 to kind of 60. It's more common. So there is a hormonal component. So it's one of many reasons. But yeah, when you do hormone replacement, it can help with frozen shoulder, but it's not a across the board treatment for frozen shoulder.
So could you explain, doctor, how you do your assessment in terms of the testing that you take to kind of confirm what it is and what it is not in terms of your lovely graph that you showed us
Yeah.
yeah. Could you tell us how you assess where somebody is hormonally in terms of all the hormones or hormone panel? Like just walk us through
Yeah.
that.
So my hormone panel will usually include estradiol, testosterone, and then the upstream hormones, which would be DHEA, pregnenolone. I'll do a cortisol. Now, some docs will do a cortisol spit test where you can check the cortisol throughout the day. If you want to save a few bucks, you could just do an 8 a.m. cortisol, and then you can kind of balance things out intuitively based off blood work. But yeah, if you go by the book, some doctors will want you to do the spit test to check the cortisol throughout the day because the morning it only gives you the morning. It can change. Other hormones that we'll look at, we talked about pregnenolone, DHEA, yeah, cortisol, and then progesterone. Obviously, we need to look at progesterone levels. And then to confirm if someone is in menopause or not, the classic thing, and this is the regular docs are up to speed on this, which would be FSH, LH, follicle stimulating hormone and luteinizing hormone. If those are very high, like super, super high, those hormones are released from the pituitary and it talks down to the ovary. So if the number is high, that means that the body is the detecting like, hey, I'm not getting enough hormones. I need hormones. So it's yelling at the ovary. So the FSH and LH are high. So you would want to see those. And then for if someone said frozen shoulder, we would do that whole hormone block we just mentioned. But then I'd also need to look at other things like thyroid. Low thyroid can cause joint stuff, and then we do like lupus, rheumatoid, autoimmune, all that will also have to be done. So it's not just narrowed on just that symptom.
So
I want to
basically,
Okay.
just a recap.
Wait,
So
wait, wait,
so
wait,
just
wait, wait, wait. We got lots of questions coming through.
okay.
Yeah,
So just
but Patrice, once
lots.
while you're
Mhm.
letting the next question come in, I just want to say, Dr. Amar. So the funny, well, not even the funny thing is, most doctors will not go through that panel,
Right. That's what I was gonna say.
right? They won't, and so they may go through some. I would actually visited a doctor last week, and she told me, now she's younger, so she may not been able to relate, but she said to me that they don't treat the patient. They treat the patient based on how they feel, not their numbers. So, Adrian and whoever else asked that question about your doctor may not do it. So that's where you have to potentially have a functional doctor and then you have your primary care. I'm going to leave it there. Patrice, I know we had a couple of other questions. So I think Melanie had a
Yeah,
question. And
yeah,
then Gayla, I see your
yeah,
hand up. We'll
yeah.
get to you.
And then Gayla.
Mhm.
Okay, so first, the question is, Dr. Amar, what's the benefits of the estradiol? Am I pronouncing that correct? Patch,
estradiol.
estradiol patch versus the cream. Should you check your levels when you take either of the two?
Yes. So vehicle matters. So some people prefer the patch just because it's not like as annoying to take. You do it twice a week. There are some patients who are sensitive to estrogen. So if you're a patient who said, "Oh, I was given birth control and it always messed me up. I had all these problems. I have really bad PMS type symptoms," then the patch can be dangerous, not in a bad way, but it can cause too much estrogen to come. So when we do vaginal estrogen, um, it is a lower dose, and then we do it vaginally, so it's going to help in that area where you need the help the most, but it can still have a systemic effect. Now, patch is easy and good, and it works, and it's also easier to kind of check your work because you can check blood levels, and it shows pretty good with blood. Whereas if we're doing vaginal cream, then usually you want to be doing another test, like a spit test, a saliva hormone test to kind of see where it is. So I've done both. It just depends on what works for the patient. But if someone is sensitive to hormones or they want to kind of dip their toes, I start with vaginal first. If someone needs a lot of help, like for bone, they really need a lot of hormones, patch is good. Or if they just ease of use, right? Or they don't like using vaginal cream. Yes.
All right, moving on to Gayla, you have your hand raised.
I have a question. What are some of the negative side effects that can occur or may occur when starting hormonal therapy?
Yeah, so the classic is if you overcorrect as the doc and you give too much, then yeah, we can make a patient have a cycle again. We can cause bleeding.
Mm.
We can cause breast tenderness.
Hmm.
We can cause fibroids, and we can even feed fibroids
Mhm.
if the protocol is not balanced.
How
So
about
yeah, that
after you
all
had a
comes.
hysterectomy?
Yeah.
So how,
So go
Well,
ahead.
you had a hysterectomy, Gayla? Is that what you
yeah,
said?
how about so after you've had a hysterectomy?
Yeah, so if you've had a hysterectomy, the only other potential thing is if we're dosing incorrectly, is if you develop like a breast mass and it is hormone sensitive, the any hormone can feed it. But there's a
Mm.
split in the community. So like amongst docs like me, we don't think hormones out of whole cloth will cause cancer because if that was the case, then 20, 30-year-olds, well, it's happening now more, but that's xenoestrogens, that's a separate issue. But that's one of the risks. So what you want to do is make sure, okay, what's the family history? Is breast cancer a big concern? Some people do BRCA testing. There's a lot of options you could do, and then especially in patients who are hesitant, you can like look and investigate, look at
Mhm.
the old memos or ultrasounds you had and then decide if you want to start. And then if you wanted to start super light, I always start vaginal.
Okay then, because at one time I was taking it was like a tablet, a suppository type tablet, and so
Yeah,
I'm no longer taking anything right now because now I'm going through that breast mass and the double and having to go through all that stuff now. I'm currently going through that.
yeah,
And
that's
also, yeah, and so I just stopped taking everything. And also what also struck my attention, what you said was the bone, the bone
the
mass.
bones. Yeah,
Yes, because over the weekend I was away and I just hit my finger on a chair and then fractured
yeah,
fractured my hand. It seems that I fracture easily. Um, and staying up late at night, it seemed like right now I'm just restless and I have to take a lorazepam or something just to kind of help me go to sleep because I feel like I just can't sleep. I'm just up all day. And then when it's time to go to sleep, then I can't sleep. Then I'm just sweating all night. Then I'm up all night. And I
yeah,
just, I mean, I'm going through that right now. My husband said, "You just hot. You just hot." He can't even
yeah,
touch me because I'm just hot. And I mean, and when I say I'm sweating, I mean I am just
drenched.
sweating all night to where I can't sleep till I'm just restless to where I may be talking to someone at work like today, and I just say, I just need a moment. And I just
Yeah,
walked away from them. And I just went outside because I couldn't even think and I couldn't even gather my thoughts anymore.
Mm.
yeah.
And
So
so
it
I don't
gets
even know what to
difficult.
do with that.
Yeah, because if you're dealing or you're worried about breast, then that closes a lot of options for safety's sake. But
Hmm.
there are even herbs that we use that are non-hormonal to help
Hmm.
with menopausal symptoms. Now, it won't do all the help. It won't rebuild your bone. It doesn't have the
Hmm.
long-term stuff, but it can help you with sleep, hot flashes, mood. Yeah,
It could
there
help
are,
manage some of the things that's going
yes,
on.
there are a
Okay.
lot of non-hormonal options as well. So like um one of my favorite perimenopausal slash menopausal medicines for that is called Estravera. through metagenics, and that's like a very common thing. So, and it's just like a wild rhubarb
Okay.
root,
Can you spell
Right,
that,
okay.
Dr. Amar? Estra, what was it?
Estrovera. So that's spelled Estrovera, and it's from a company called Metagenics. They recently changed the name to it called, I think it's called like Her Wellness Estrovera. And then that
Yeah.
one's easy. It's like there's nothing in there. It's just the rhubarb root. And I've had a lot of patients they get on that. And especially if we are kind of boxed in, you can't do hormones yet, then yes, that is a way to get at least get some relief.
Talk to
But
your
but
doctor
but
first, Gayla, before you start taking
Always
any
talk to
yeah,
your
talk to
Yeah.
doctor
that. Yeah, and then
Yes.
before
also
you
So
the
take
I
any
would,
new supplements.
yeah, and
okay,
also
I would talk to him.
she'd probably be a good candidate to do a panel because she's going off
Of
for her.
course.
Yeah, because it sounds like you don't know exactly. To me, that's what I did. I went and got my numbers checked because I didn't know for sure. But once you get your numbers, you know for sure what you need,
Okay,
what you cannot do. Yeah.
and
And
I
this
need
is
to
our
get that
plug
from
for
my doctor, right, to do a blood test?
Yeah, but so
Okay,
like if you are fully menopausal, doing an estrogen progesterone, it's gonna be low. So in my practice, if we know the patient's menopausal and there isn't any risk factors for breast health, you start and then you check your work on the back end. So like you would do a treatment program and then you kind of navigate and you see, okay, we gave this much medication. How is she responding to it? Is it too much, too little? And then you have to tweak either based off labs or based off clinical outcome.
okay,
Yeah. And
okay.
then all those other hormones as well, like you talked about, Doctor.
Yes, you
She got
have
to look at all the hormones and see
the ones
what's
that are more important to
triggering.
do before is the DHEA, pregnenolone,
Yeah.
cortisol, because the estradiol and progesterone will be low. If you're menopausal, it's going to be zero. So you can still do it, but it's not as important as the other hormones because you want to see what's happening upstream, like I showed in that image.
Okay.
Dr. Amar, while I get to the other questions here, can you explain the difference between an MD and a DO,
Yeah.
functional
Sure.
doctor?
Yeah,
Yes, I
I get
can.
this one all the time. So there's two medical doctor types that are allowed in the States. There's the doctor of osteopathy, which is DOs, and then there's MDs, which is the more traditional MD. So back in the olden days, there were osteopathic hospitals. They were very kind of like separated. They did their own thing. The DO kind of moniker, it was basically the idea is to treat the whole person, and it's a whole body kind of approach to medicine. And the original, can you still hear me?
Yes.
Okay, yeah, it sounded weird. The original person who did all the work with osteopathy was doing manipulation. So it was doing actually movement and trying to fix incorrect um, alignments in the back or the muscles. Sorry, that fell out. But nowadays, a lot of doctors just work as who are DOs will just work like an MD, and they go to the same residency programs. They can go be a dermatologist. They can be a neurosurgeon. So a DO is just like a different degree, but it's still 4 years, 4 years after med school. Still had to take the MCATs, and then I was in the hospitals. We do residency programs. The residency programs before, during my training, they were kind of separated, but now a lot of them are blended. So you can go to a residency program now, say if you're going to be an ER doc and you're with other training ER docs, and some will be DOs, some will be MDs. So
Okay.
it's just a different mindset of medicine, but we can do all the same work.
Okay.
They work. Lots of questions coming in. So this is a really good question, and this hits home for me, and I think my sister too. Question. Not sure if you've talked about it, but what is the relationship between cholesterol and perimenopause, and is there an end to treatment?
Hmm.
Yeah. So in a lot of my patients, if we can remember our paper, well, maybe I should share it again. Huh? Yeah, let me just share it again. If we remember our paper, cholesterol is the main hormone. All the hormones are needed from cholesterol. In my experience, what I have seen in menopausal patients, now there hasn't been a double-blind, placebo-controlled study from a big ivory tower place, so not they may not agree with what I'm about to say, I have found that in my patients that we treat clinically, if we address the downstream hormones, we'll see the cholesterol drop a few points because your body is trying to fix the problem. And it will sometimes upregulate cholesterol production to help downstream. So if you fix the downstream, then there's less reason for your body to make that high cholesterol. So that's why a lot of women will notice as they get closer to menopause, cholesterol starts to jump up like crazy. And that is a common pattern I've seen. I wouldn't say hormone replacement is a treatment of itself for cholesterol, but it can definitely modify it. And a lot of times, if it's like borderline, if you address the downstream hormones, then you may not need to. But obviously, if you have cholesterol super high and there's other reasons, yeah, you probably still might need to work on it. So it just depends on the patient.
Yeah, I will say that was my issue when we did my blood work because I am a pescatarian. I eat pretty clean.
Yeah.
So I couldn't figure out why my cholesterol was high, but then you explained it to me. You said my brain was going 100 miles an hour trying to regulate estrogen and everything else in my body. And then my cortisol was high because I was pursuing my MBA, work stress, all the things. So that did not help either. So
Yes.
yes, so I'm working it down. So hopefully next time we do my labs, I'll
We'll
be
see.
right in line with where I'm
Yeah.
supposed to be.
Yeah. And
Okay.
and the other big draw is the cortisol, exactly what you said.
Yes. Patrice, go
Next
ahead.
question. Question about I'm thinking it's the pill for pregnancy prevention. I'm guessing that's what it is. But what about the pill while we're talking, or I think it's a typo, maybe taking estradiol while we're
No, I was
taking.
Patrice. I was
Uh-huh.
asking because I came in. I apologize. I was late. It's Melanie Gunn.
Yes.
I heard him talking about the estradiol and the cream and something else. So I was asking about the
Yes.
estradiol pill versus
Yes.
the cream and whatever the other method was with the estradiol, the patch, I think you said.
Yeah. So for the in what way are you asking about the pill?
So in terms of like effectiveness or safety or because I take
Administration
the
of it.
pill.
Hmm.
Yeah, so the estrogen pill is very effective. It will help and it really helps with the bone. The reason why I don't do estradiol pill, I'm assuming it's probably like the 1 milligram estradiol pill. Um, it,
It's
it
point
zero
five, I
point
think.
0.5. Okay, so
Hmm.
lower dose. Yeah, so that estrogen pill, if it's just the estradiol, it's not balanced. So unopposed estrogen in our world, in the functional holistic world, when we do hormones, we don't like doing estrogen by itself because we feel that if it's not balanced with estrogen, with progesterone to kind of balance it out, it can increase risk of like fibroid growth, breast tenderness, PMS type symptoms, or even potentially fuel a tumor growth or something like that. So it always has to be paired with progesterone, but it does work. And then the other concern when you do the pill is it hits your body much harder and it goes through the first pass metabolism. And so because of that, we tend to see higher incidence of like risk for blood clot and things like that. That is more common when people take the pill, but when we do cream for hormones, blood clot risk is negligible. So it's just a habit, but it can work as long as if your doc is watching your numbers, making sure you're balanced with progesterone. But it's not something I like to use. I have a once in a while I'll put estradiol pill, but I'm not a big fan of it.
Okay, thank you.
Of course.
We have a pretty long question here.
Yes.
There's a breast cancer survivor here
Hmm.
and thriver with previous hysterectomy and believes birth control may have caused the fibroids that led to hysterectomy and may be the cancer. Question: would Marina, am I pronouncing that right? Mirena
Yeah,
birth
Marina.
Marina birth control have any contributions towards the cancer if BRCA was negative?
Um, that's a tough question, but typically if it's estrogen positive, but you're only doing progesterone from the marina, it's not a lot of hormone. So it's unlikely to be a huge issue. And typically, if you are a fibroid grower or had fibroids, typically that will clue us in that you may not have had enough progesterone and you may have had too much estrogen, or too much estrogen and not enough progesterone, or any sort of combination where you're what we call estrogen dominant. But as far as like depending on your cancer type and what the cancer is fed off, I don't like to use estrogen heavy treatment in patients like that. I would might do indirect, like we might do some of the upstream hormones and see how that trickle down works. And then the other component would be some of the herbs, like the Estrovera or something like that. But regarding the Mirena is not like a Mirena doesn't cause a lot of hormone dysregulation. For a lot of women, if they're having problems with heavy cycle fibroids, the Mirena can potentially shrink it. So it is a foreign object. So if the patient's sensitive to foreign objects or has a risk of autoimmune, sometimes that the actual structure of the Mirena can trigger. So yeah, but would the Mirena birth control have any contribution towards the cancer of BRCA? Usually not. So to answer your question, usually no. I kind of went all over the place.
No, that was good. You brought up autoimmune several times, Dr. Amar. Is there any
Yeah.
connection between autoimmune immunity and menopause? Because I know for me that came out of nowhere, and
Yes.
stress and all of the above.
So there are some theories, nothing is 100% yet, that when the hormones drop, there can be new onset autoimmune. We also know that the hormones are highest when a patient is pregnant. And oftentimes, when they're pregnant, the autoimmune also shuts down. Now, part of that could be so your body doesn't reject the developing fetus. Potentially, it's just that, or it could have to do with the high level of progesterone estrogen, which has like an anti-autoimmune. But I don't use sex hormones by themselves to treat autoimmune, but it could theoretically help by having the hormones corrected. It can make the autoimmune maybe not bite as hard.
So, question about vitamin D, because one of the things when I did my initial panel, like
Yeah,
everything, cholesterol was high, all insulin was high,
and D was
vitamin D
low.
was low. Just a
Yeah,
typical panel
the typical.
results. Yeah, but when I got the treatment, everything just lifted. Do you see that with your patients once they get their hormones balanced, their vitamin D's come up somewhat, their cholesterols come down, all the things that was out of whack kind of starts to realign themselves once they get the proper
Yeah,
adjustments.
it could, but I usually just give vitamin D in addition to the hormones, because vitamin D is so important.
Yeah,
So yeah, that is a important hormone that some patients just are very deficient of. It could be due to diet, but there's also ancestral differences. So amongst my patients of African ancestry, there's some theories that darker complexion, it's harder to absorb the D. So even some were saying that that could be a potential risk factor of why COVID hit certain populations harder than
yeah,
others due to vitamin D levels. It's not as simple as that, but
yeah.
yeah, that is a theory out there. But yeah, D is super important. All my patients get tested for D.
Hmm.
A lot of the insurance companies, they hate testing for D and they'll try and bill patients for it. It's really annoying, but no, there's so much good data behind D. So D is very important. I like to have it because it's for your immune system, it's for your mood. That's why when people live up north, like Alaska, and they don't see the sun, they get seasonal affective disorder. It's also for bone health.
What about
But
H1ACs, the whole insulin and all that stuff? Does that go crazy too? I know when you do
yes,
the
yes,
panels.
you're talking about the hemoglobin A1C?
Yeah, absolutely. That one.
Yeah. So the hemoglobin A1C can be affected when patient goes into menopause. If it's an early menopause, typically it might be more cortisol driven because the high cortisol will lead to high sugar. So it's
Mm-hmm.
more related to that. But then you'll come at that patient or the patient will come in with the initial presentation, hey, it's menopause. And then you'll say yes, and
Gotcha.
you'll have to look at the other stuff too. So like the cortisols play a role. Yeah.
can feed the high insulin, which feeds the weight gain, which feeds the, all
Yes.
the thing. And so when you revert, one thing I noticed that once I did get everything under control, the damage was already done, like the weight gain, all the things. So you still have to work on it, even though I wasn't gaining a pound every day and it stopped, but all the damage was done. You have to kind of come back and clean it up on your own. Now you're kind of
Yeah.
right. Is that kind of what you see too as well?
Yeah, so I use the idea as like you got a camel and you got all this packed on the camel. Eventually, you put too much on the camel and then the camel falls over. You have to take everything off the camel before you can stand up again. That's the kind of the idea we're saying.
So, Dr. Amar,
Mm,
the buzzword peptides. So that's
yes.
been a hot topic.
Yeah.
So peptides, what can you tell us about peptides? Is there or are there any peptides that will help with the menopause or symptoms, perimenopause, menopause, postmenopause symptoms? What is there? What's out there that will help with all the symptoms?
Okay. So peptides are very small molecules that can have like a cascading effect on the body. The most famous ones are going to be the GLP ones, right? So that's going to be your tirzepatides, Ozempics. Those are mainly for weight loss, insulin resistance, but they also have anti-inflammatory effects. There are some peptides. I haven't used all of the peptides that are available, but there are some peptides patients are using for hormone optimization. But the hormones that the peptides will target are going to be more like growth hormone and not directly estrogen or progesterone. And then there's other peptides that just help with collagen production, like GHK copper and stuff like that. And then there's anti-inflammatory peptides like the BPC 157, TB 500. So it's just a suite of treatments. But peptides to me are like the new thing. So everyone's like, oh, just get on the peptides. I always think of as peptides as icing on the cake. So you got to have your foundation,
Mm,
have all your low impact stuff happening because there's some guys out there who will do like 4 or 5 different peptides, and each peptide is 200-300 bucks a month. And
mm,
before you know it, it's like $1,300 1400 just a month just for peptides, and it's not really a cost-effective way to treat. You have to have peptides if you need them. Yeah, that's fine, but you got to have foundational first.
mm. That's good. Now, one question I want to ask, because it was in the list that I read off earlier about different things that people see going through menopause, and anxiety is one.
Yeah,
And so, how does menopause affect the nervous system? And explain what
yeah,
the nervous system controls.
yeah. So the nervous system is there's different parts of the nervous system. The thing that gets messed up the most with most patients is the brakes of the system.
Mm,
The system, those brakes are called the vagus nerve. Part of it is the nerves. The vagus nerve helps slow you down, helps you be relaxed. It helps you allows you to digest. And actually brings up a nice little image I have here. Let me show you. So the nervous system, uh, we've got what we call the sympathetic nervous system. And then we've got what's called the parasympathetic nervous system. So the sympathetic nervous system is that fight or flight. So when your body is looking to see where the bear is hiding, or you're running away from the tiger, that's that innate primal fight or flight. And then the rest of the gist is the parasympathetics. So in patients, when we're hitting menopause early, we can sometimes get those patients where they get stuck on this side of the graph. And so they'll notice that they have dry mouth, their digestion gets worse, they're more bloated after they eat, they feel like they can't break the food down, they might get constipation. They will notice that they're not producing enough acid. And then when you're in fight or flight mode, that's going to cause those patients that we talked about earlier, as men, how do we support our wives? If you just, touch her shoulder and she's like, stop touching me, they might be stuck in that fight or flight, that sympathetic overdrive. So, yes, you could do the hormones, but that may not fix this piece. So then you also have to open up this piece. Like, how do we reduce the cortisol? How do we balance that out? Because the libido is not just testosterone. Like, if we're treating men and women, 9 times out of 10, you get a guy's testosterone up, he's, he's going to be okay. Ladies is a little bit more complex. The hormones have to be there, but then you also have to be in a restful state to be kind of quote unquote in the mood. So that has to happen. So like, everyone knows that, oh, if someone had a bad day or someone pissed someone off, hey, it may not happen tonight. And this is part of this whole pathway. So
Good,
yeah.
good. Okay, and then we're going to wrap up here sh shortly, but one other question. We have some seniors on the call, and who have been in menopause for, 10, 15 years. What recommendations do you have for them to maintain their hormone levels, and what supplements should they consider taking, if there's anything that you can recommend to our seniors?
Yeah, so if we're looking at menopausal patients who've never done hormones and they're postmenopausal 10, 15 years, the window to help support your bones and those sort of things may have passed. So the benefits you're going to have would be pelvic floor. So doing some low dose hormones, very low doses, probably not going to even show up on blood testing. When you do the low dose hormones, it can help with vaginal dryness. It can help with pain with intercourse if that's still occurring. It can also help with pelvic floor dysfunction if you feel like you have prolapse or any of those concerns. It also helps reduce UTI.
Mm,
Commonly in that patients, they get frequent UTI. If we get hormones there, vaginal, just right where it needs to be, that will make it less likely that the patient can develop UTI because that's a classic thing we see in our postmenopausal patients. So the bone component, you're not going to be able to do it. And I personally don't go heavy on hormones in that population because now we're just throwing too much at the patient. So I like to kind of go gentle. And then the other things you would look at would be those upstream hormones we talked about, like pregnenolone, DHEA. Pregnenolone is also known as the memory hormone. So it is the mother of all hormones. So when the pregnenolone gets chewed up, patients are going to have brain fog, word finding, and then obviously in that patient population, you want to optimize those hormones before you say, oh, well, I've just got a few years. Maybe that's why I'm forgetting things. No, it can just be pregnenolone for all we know.
mm, okay. All right. And then was it another question came in
Yeah.
regarding go ahead, Patrice.
Magnesium.
Mm.
Regarding the nervous system, do you recommend magnesium? I found it to be amazing for MS at night to sleep much better.
Yeah,
Probably
I'm
me.
probably me. Yeah.
Yeah.
Mhm.
So yeah, I use magnesium all the time, and it depends on which magnesium you want. So if a patient comes in and says, "Hey, I've got constipation and insomnia," then I might reach for a citrate. If the patient says, I took magnesium and it gave me the runs," then we'll reach for a different magnesium, like a glycinate, malate, threonate, and then those will work on the brain and the muscles better. Oh yeah,
Dr.
I can
Mark,
I
could
can
you? Okay, can you type it in? Thank you.
It's pregnenolone. Is that the
pregnenolone.
Yeah.
pregnenolone?
Yeah,
I
so
take that one too.
sometimes people get it confused with progesterone,
Yeah, I was gonna say that.
because it's right
Above.
above it, and that one it's a supplement. You don't need a prescription. Whereas progesterone and estrogen, you'll need to see a doc to take them. Obviously, you should always check with your doc before you take any supplements. But like pregnenolone, when you check your levels, like you could get that at the store. So before they invented steroids, they used to use pregnenolone. Those as a precursor steroid. But
So
that's a little
are they interchangeable? Can you use one as opposed to the other, like the progesterone over the pregnenolone? Are they are
no.
oh yeah, okay.
So they work differently and they work for different things. So like say for example, if we have someone who's overworked and they're in their 20s or 30s and they can barely get out of bed, they're so tired, they're having brain fog, they're forgetting their colleagues' names when they go into their team meetings. Those type of patients, and they're not menopausal, you might see that, okay, you've been working 8 hours a week, you've not been rebuilding your Zen, you haven't been rebuilding kind of your relaxed time, then yeah, the pregnenolone will be torpedoed because your pregnenolone will get chewed up by your adrenaline. And so your cortisol will kind of take over and steal all the pregnenolone. So we'll see that. If it's low, then I'll be like, or if I have a patient I've been seeing and pregnenolone was good, and then I'll see it's at 10, they'll be like, oh yeah, all this stuff happened. I lost a family member, my job changed, my dog died, whatever. Will still tell me the whole story. And I'm like, hey, something happened. They're like, yeah, this happened. So that's, yeah, the pregnenolone, I use it personally as kind of like a litmus test of stress.
I take that for everyone out there. I take the pregnenolone, and you can get pure encapsulation. They sell
Yeah,
it on their site, and it's would you call it vegan? I don't know, Dr. Amar. It's
yeah,
it's a pure,
very
um,
clean.
very
Pure is a
clean.
very good company. Um, all their stuff is gluten-free, dairy-free, corn-free, soy-free, egg-free, and pregnenolone is pretty cheap. So like compared to other supplements, pregnenolone, you can get it for very cheap online or through my office or wherever.
Yeah.
But there's a lot of good supplement companies out there. So I always tell patients, if you're on supplements, we'll take a look.
Yeah.
And if you like a certain supplement, that's great. Let's check the work, trust but verify. And then you see, okay, the number comes back not so good. Okay, then maybe I might switch you to brands I'm more comfortable with.
Mm. But you
Okay.
have a suite of brands yourself, doctor, is what you're
Yeah.
saying. Oh, good,
Yeah.
good.
So I
Very
have
good.
my
One
own
stop shop.
brand. Yeah. So we do it for convenience, but I have a ton of patients we see and they might have friends or family members or they have like a discount code and they can get stuff from another company. And then I'm all for it. I'll tell you what you need. Like, I'm not going to be like, there's only one way forward. That's
Nice.
not how life is.
Thank you,
Okay, we
doctor.
got one more question, and then we're going to wrap up.
One
See.
more.
Go ahead, Adrian.
So this is kind of like a non-medical.
Yes.
How important, because we understand the medical aspect. How important is it to find support?
Hmm.
I The emotional support for me was kind of lacking because I felt like I was the only one going through it. And so there was like this isolation in which I detected like some kind of depression. And I had fought depression years ago, and never would allow that back into my space. But I was just like, I'm learning a lot, and I really want us to be okay. What do we do for support?
Yeah. So, I mean, community is so important. And so that's why, I personally see why in younger generations we're seeing more mental health because everyone's isolated, too many, social media, news can be overwhelming. And so it's very important to have that community because human beings are social creatures, right? We're supposed to have community. We lived in big groups for a long time, multi-generational. That is very important in my opinion. So like the whole idea that, you had your auntie here and that community is very important. And I think that's something that is being lost these days, which is a societal problem, yeah. But yeah, very important to walk through it with community because that, then like, hey, I've been through this and now we have tools we can help. Yeah.
Yeah. And we're
Thank
also
you.
here. We're creating that community, right, Pamela? We're trying to
Yes,
create that community.
absolutely.
Yeah.
Yeah.
Absolutely. And
100%.
one last thing, Dr. Amar. So, we've covered a lot today. And
Yes.
give our audience one thing if they're dealing with hot sweats or you can't sleep, is there one thing that they can start tomorrow on their journey to feeling back to being their old self 100%, however we want to describe that. Is there one thing that they can do? And it may not be, right? Because I know just depending on
Yeah.
what it is, you might have to do estrogen, you have to do the cream, you might do pregnant, whatever. But is there one thing that we can give people to start with to on their
Yeah.
road journey back to being 100%?
So there isn't a one thing because it depends, right? You answer the question. Estrogen, progesterone, pregnenolone, thyroid, micronutrients, vitamin D, B12, all those things are so important. So you have to check everything, make sure everything looks good. But if there is one uniting thing that causes chronic disease for me, is patients who are stuck in fight or flight mode and not getting that adequate recharge time. So like even myself, like if I watch too much news, get your labs. Oh, and then my wife sent me a text. She says the answer is get your labs. She's so much better than me. Yeah. So yes, yeah, my wife is my greatest ally, my biggest support.
I
So
love
shout out
that.
to my wife. And so yeah, she texts me. I can talk all day, and she's just like, no, just get your labs. Yeah, that's the perfect
Yeah.
answer. Get your labs. That's the answer.
Yeah.
So,
And
Doctor,
so to be specific, meaning doctor, you mean go get tested, right? You just
Go get your labs.
get all
yeah,
your tabs, your
yeah.
testing done.
That
Yeah.
is the most important thing. Because if
Yeah.
you don't have
100%.
data, you're just guessing.
Hmm.
Yeah, get your labs. That is, yeah. My wife, she's the best.
Yes.
She's very succinct. That's what it is.
And I want to advocate, and I mean, I know people have their personal preferences and they want to see their primary doctor versus a natural doctor. And I say consult both, right? Because your primary care may not be willing to do the go to the lengths that Dr. Amar has done for me and Patrice. But again, as we put in our chat, use the discount code Vision Creator 26 if you're interested in calling Dr. Amar's office and scheduling an appointment with anyone in his on his staff. But
Yes.
he will start from the beginning, getting all your blood work, and he'll know how to treat you. And you can take that as a start, take that to your primary care, and be prepared that they're going to probably not support that. Like the doctor said to me
Yeah. The
last
regular
week,
doctors. Hmm.
she said to me that, oh, I wouldn't do any of that, but that's, that was her recommendation because she's
Yeah,
a
that's just
primary
the
care.
train.
Right, that's right. So again, go both sides, get and go with what feels right to you, right? And if you feel, some kind of way about putting things that maybe synthetic in your body, then I would encourage you to go the natural way and trying
Yeah.
supplements and seeing how that works for you. You may even feel better than what the synthetics are because you'll have side effects from the synthetics. Anyway, so my point is, give Dr. Amar a call or someone like Dr. Amar in your community. Find a naturopathic
Yes.
doctor.
Yes.
And again, you will get the benefit of a discount because you have the opportunity to meet Dr. Amar here, and he's offering a coupon code, discount code if you use Vision Creator 26 as when you call to make your appointment.
Yeah.
Yeah.
And just,
And for those of you in other states and stuff, there's also a website called ifm.org.
Mm.
And what they have on their website is they have a find a practitioner page. So you could see near you who's gone for extra training and who is a certified and taken tests and done the work and is actually gonna have the same mentality that I have. So that's the group I'm part of, the Institute for Functional Medicine. And so this is kind of there. You could do a practitioner lookup based off your zip code, and then you say within 25 miles. Now, I can't speak for everyone here. I don't know everyone, but you could find someone that might, it gives you a list of options of allied professionals that we go to the same conferences, we have the same outlook. Because the functional medicine is not looking for what's the one thing wrong with you. It's looking for all the small things that we can optimize to get your health back.
yeah. And I
Awesome.
and I second what Pamela said. I went to my gyno and my primary. They couldn't help me. But when I came back and gave my testimony about how much better I felt because I did my labs, and I didn't try to waste time and figure things out. Because you're wasting time if you don't do your labs and you're suffering, you're wasting your time working with somebody who have to guess. Doing the lab takes all the guesswork out. They can pinpoint and they can solve it immediately. I mean, the results were overnight, literally. Everything. And so when I came back to my primary, my gyno, and I showed them my results, they're like, "Oh my God, where are you going? We might need to go. We might, they start asking me where I'm going as a referral, and these are my doctors.
Yeah,
So don't waste
I
your
see a
time.
lot of doctors.
Yeah, don't
Mm.
waste your time. Just get your labs, know where pinpoint exactly what's wrong with you, and they can adjust. So yeah,
Yeah.
so doctor, go ahead. You see doctors, right? Go ahead.
Yeah, I see doctors. I see executives as well. So
Yeah. And I will say from my experience, so my insurance doesn't cover Dr. Amar, but it does cover the blood work.
yeah,
So it's not all out of pocket. So just keep that in mind, and it's worth it. Your health is worth it, right? The
Hundred
health is
percent.
wealth. Health is wealth.
yeah. We'll
100%.
spend usually our first visit is a whole hour. Our second visit will also be an hour, and then our subsequent follow-ups we'll do in 30 minutes. And so you're definitely gonna have time to talk, tell us your story. We need to understand a lot of things. So that's why it's like I don't have like any buzzwords or like a treatment protocol, or you have to do this. It really is, it's tailored. So exactly like my wife says, get your labs. She's
Awesome.
usually right.
Dr. Mar, we
Thank you,
can't thank you
doctor.
enough. Thank you so much for your
Yes.
time, your expertise, your energy, and
Yeah.
being patient with all
Yes.
the questions. As you know, because you see a lot of patients, women are going through
Going
something.
through.
It's tough for a lot of us. And so to be able to seek out and now be open about it, it's an open conversation where it hasn't been. And so we were suffering in silence.
Yes.
So I'm glad that now I see commercials and all the things, and people are open now to listening and wanting to help. So thank you for coming onto our
Thank you,
platform.
doctor.
And we hope
Yes.
that,
We
it has
appreciate
been
you.
helpful to everyone on this call. And anyone who listens to the recording, I hope that people find some help. They find the help that they've been desiring. And so again, thank you for your time. And Debbie, anything else before we adjourn?
No, as far as the community, we're here. We're trying to build a community where we can help
Yes.
each other, get resources for everybody. So thank you for your time, everyone. I know
And
it's
yeah,
late.
and follow us. You can find us on YouTube, Vision Creator, on YouTube, and Creator is CreaTher. Please subscribe to us, and when this recording is ready, you'll be notified, and so then you'll see the recording if you're interested in seeing it again or sharing it with your friends and family. So again, thank you, Dr. Mar. Everyone, have a great
Thank you,
Yes.
evening.
doctor.
Thank you to
Thank you
Thank
for
you,
everyone who
having
everyone.
me.
joined. Thank you, thank
Thank
you,
you for
thank you,
having
thank
me.
So
you.
long.
Have a good evening. Thanks,
Good
everyone.
night.
Good
Good
evening.
Good
night.
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 Bye.
Bye.